It's always nice to have a little vent sesh. Today, we're going to talk about our pet peeves as reproductive psychiatrists. I'm Dr. Nichelle Haynes.
I'm Dr. Kristen Lassiter.
And we're medical mamas. This is your place for evidence-based information about your reproductive mental health.
Meaning we'll talk about mental health in relation to reproductive hormone changes that happens like around your period, pregnancy, postpartum, menopause, and infertility.
Where should we start?
So,
I know.
okay.
Telling people to test their hormones in the postpartum period.
Or
What are you going to do with that?
Yeah. Or even just like saying, like if someone's struggling postpartum, saying we should test your hormones and like supplement with progesterone or something.
There's no evidence about that. In fact, the evidence that is around that is like, probably don't do that.
Yeah, there is evidence saying it might be bad.
It's just, I think it comes from a place of like, wanting to do something helpful, or maybe it's predatory, right? That sometimes it's just like, oh, I can make $3,000 off of this person who's struggling, right? Like that's a big pet peeve, is like taking advantage of people. But if it's testing hormones, there's no evidence to do that. And then what if you have something, what are you going to do with that information?
Yeah, your hormones postpartum are changing, like that whole 12 months postpartum. They're going to be low. They're going to kind of change and readjust. And that's normal. That's a normal part of what happens after you go through like a whole pregnancy and all those hormone changes. And it's not necessarily, we've seen this over and over again, it's not the level of the hormone that causes psychiatric symptoms like depression or anxiety. It's the change in these hormone levels that tend to be the trigger for that. So just testing hormone levels isn't going to give you an answer or tell you anything about how to treat somebody's depression or anxiety.
Well, I don't know what I'm like falling down.
Mic drop.
Pretend. Okay, what have I got for you?
Okay, so another big pet peeve for me is when patients are just blanketly diagnosed with PMDD by another provider without really having a discussion or, really understanding if it's PMDD or if it's premenstrual exacerbation of a mental illness. And so just spending like 10 minutes, even spending 20 minutes with somebody, I don't feel like is enough to really understand whether or not they have PMDD. And then just throwing, again, like hormone treatments at them. Really, hormone treatments don't have a lot of evidence for treating PMDD. So the first line treatment is psychiatric medications anyways, but it's just a big pet peeve of mine.
Yeah, I think you see more people with PMDD or who think they have PMDD than I do. It makes sense that like that's really frustrating.
It is really frustrating.
And you're supposed to like monitor it for what, 2 months or something beforehand?
Yeah,
like some scales?
You're supposed to be doing scales in order to get an official diagnosis. You're supposed to be doing prospective rating scales, meaning each day for 2 cycles, you kind of mark down what symptoms are. And there's a whole like specific rating scales that have been studied and are evidence-based for that. So it's a whole process. It's not just like a 10-minute conversation of, I think you have PMDD, here's some birth control to help.
Right. Also probably coming from a good place. Let's try this. See if it can help. Telling people to stop their meds.
When they get pregnant?
Yep. Oh. I mean, we have videos on this. We probably don't need to elaborate.
Let's elaborate.
I'll wait the video as well. Okay. I'm sure the idea behind stop your medications is this medicine might not be safe for baby. And the thing that is not considered is what is the implication of the illness. And I would say for the vast majority of psychiatric medications and the vast majority of people who need psychiatric medications, it's riskier to stop the medicine. And I just want to like open every clinician's brain and just like drop that little piece of information in and just close it right back up. Right? Like, don't tell people to stop their medicine.
Yeah, don't do that. If you have a clinician who's telling you that too, without having a discussion with you about it, then red flag.
Yeah, we need a second opinion, at least. Yeah, for sure. What else?
So another pet peeve is when somebody is referred to psychiatry or psychiatry is consulted like in the hospital because something really tragic happened or just because they're sad or stressed. It's normal
to cry.
It's normal to cry. It's also normal, like if something really tragic happens, it's normal to go through feeling sad, feeling angry, feeling scared, all these different things, and it doesn't necessarily warrant somebody to have to go see a psychiatrist. And if you're going through a hard time, it's normal to struggle through that hard time and have a period of adjustment. There are times when you should go see a psychiatrist, and that's when life is just really hard and things are lasting and not getting better, or if you're having more scary thoughts, like thoughts of harming yourself. But in general, right when something, bad happens or there's a stressor going on, it doesn't necessarily mean that you need to see a psychiatrist or get on psychiatric medications.
For clarity, I'm not laughing that people are sad. My head just imagined, like, I don't know, this is sort of not uncommon, I would say. Like, someone who doesn't really deal a lot with mental health is like, I saw a tear. What do I do? That was what my head immediately did. That's why I was just giggling at myself. Yeah, crying's normal. I cry. Everybody cries.
Everybody cries.
Yeah. So, yeah, sending someone to psychiatry, or basically, I guess your idea is more like pathologizing a response.
A normal response.
To stuff.
Yeah.
Right. Ooh, okay. We can stop after this one. It really bothers me when it's like people use psychiatric terms as like descriptors, right? Like, oh my gosh, I'm being so ADHD today. It's like, no, you're being inattentive or you're distracted, right? ADHD is a disorder, or like a diagnosis, or like, oh, they're so psychotic. But like, are they experiencing psychosis? Because that's maybe something that needs to be addressed. But if you're saying they're like intolerable, or they're difficult to deal with, or they're like frustrating or whatever, they're not psychotic, right? Psychosis is something completely different from what you're talking about. And then it really is.
I feel like the biggest one that would bother me out of that was when people would say somebody else like acts bipolar.
Oh, that one too, yeah.
That one just drives me nuts because bipolar disorder is a real mental illness, and people who have it are like amazing people. They're not usually in a mood episode, and I don't know, you're just like, you're creating this stigma, or you're continuing this stigma on mental illness, and also kind of devaluing the disorders that make up mental illness that really need more thorough evaluations and treatments. It's not just like everybody has ADHD or everybody's OCD if they like to keep things clean or whatever.
Totally. Yeah, I think that's a perfect point. You're contributing to the stigma of illness, right? No one is like, oh, I'm so infected today because I have to go pee more than once. It's like, that sounds absurd, right? Like, oh, I'm so infected, I must have a UTI because I had to go pee more than once today. It's like, that sounds absurd. It sounds crazy.
Yeah.
That's how you sound when you're saying that.
Not you in particular.
Maybe you. It's just, please, like, we're doing work over here. Please.
Yeah.
Just adjust how you're talking, because there are so many wonderful people in the world who are already by saying those things.
Yeah. So those are our top 5 pet peeves as reproductive psychiatrists.
I think so. We can find some more, I'm sure.
First.
Okay, thank you so much for being here. Please like, comment, subscribe. We'll see you soon.
Bye.